As I was saying, the axial skeleton is made up of the skull and the spinal column, also the thoracic cage, and we looked at the skull. Now we are looking at the spinal column. The spinal column comprises of 33 bones, which we call vertebrae, and they are divided into 5 sections. First section, which passes through your neck, is called your cervical vertebrae, and the next section is the thoracic, followed by the lumbar, sacrum, and the last portion of your spinal column will be the coccyx or coccygeal vertebrae. Now, these ears are named because of the section of the body that they passes through. Therefore, as I said, the cervical passes through the neck, and that's where you have the first 7 vertebrae of the spinal column. And for information, not necessarily, well, for your knowledge, you should recognize that the first cervical vertebrae, C1, is the atlas. That's allow for the flexion and extension of the head, and also this second cervical vertebrae, C2, is known as the axis, and that's actually where you have that rotational movement of your head. The last vertebrae in the cervical section is C7, and that is the most prominent one. For the thoracic vertebrae, they pass through the thoracic region, and that's the next 12 vertebrae. Along these 12 thoracic vertebrae, you have the ribs attaches. The next 5 vertebrae in the spinal column will be your lumbar vertebrae, and they are passing through that section of the abdominal cavity or posterior section. And then you have the next 5, they are actually separated at youth or in infancy, and as you get older, they become fused, and they are actually joined to the pelvic. So that's actually the load-bearing section of our spinal column. And when we come to lifting and moving, that's where all the weight will be stacked on and supported by the pelvic, and the load is passed through to your legs. The last portion of the spinal column is the coccyx, or what you call the tailbone, and that's the last 4. So recognize these are the sections that make up the spinal column, and it's a part of the axial skeleton, and we say it's part of that main trunk that makes up the axial skeleton. Recognize also, when we look further at the function, you recognize that there are some discs that separates the vertebrae, and they are called the intervertebral disc, and they allow for some movement, bending, lateral movement, and flexion and extension, along with the ligaments and muscle that connect to them, which allow for that movement. As we continue with the axial skeleton, recognize that you have the thorax, which is your thoracic cage, and it's comprised of the next 12 vertebrae that are supported by the ribs that comes from the 12 vertebrae, and also at the front you have your sternum. So the thorax is formed by 12 thoracic vertebrae and 12 pairs of ribs. The thoracic cavity contains the heart, the lungs, the esophagus, and your great vessels. So these are contained in the thorax or thoracic cavity. And another function, we're looking at physiology. The thorax function or the skeleton overall is for protection of vital organs. And here we see where the thorax provide protection for the heart, the lungs, the esophagus, and the great vessels. And the great vessels are the aorta, the vena cava. Now we come to the next section of the skeleton as we're looking at the anatomy, and that's the appendicular skeleton. And we said it's the attachments to the axial skeleton, which is the main chunk, and that would include your arms, your legs, their connections, which we look at the joints already, and also the pelvis. So these are the structures that makes up the appendicular skeleton. We mentioned joints already, and joints occur where we say two bones meet, and they are supported by ligaments and that connects bone to bone, and tendons that connect muscle to bones. So you have the upper extremities, which we said would be your arms, and you have the pelvis, which is the main structure that the spinal column fuse to, and you have the lower extremities, which would be your legs. So recognize the difference between the axial skeleton, which is the main chunk, your skull, your spinal column, your thorax or thoracic cage, while the appendicular skeleton are the structures that connect to the main chunk or the axial skeleton, which involves your arms, legs, upper extremity, lower extremities, and your pelvis. The upper extremity start from your shoulder girdle or the pectoral girdle, and it ends at your fingertips. Therefore, it involves your arm, which is the upper portion, and it continues through the elbow, which would be the joint. It goes onto your forearm, which involves your ulnar and radius and bones, and then it goes through to your wrist, which is the joint, and then you have your hands and your fingers. So these are the structures that makes up your upper extremities. So we say the upper extremity extends from your shoulder girdle, and the shoulder girdle is comprised of three bones. It's where you have the clavicle, which is the little bone at the front coming from your sternum, and it joins to your scapula, which is the collarbone, and then you have your humerus, which is extending from the elbow to the shoulder. So all these three bones come together to form your shoulder girdle. So the arm is main bone in the arm would be your humerus, and that we say is the upper portion. So recognize the difference between arm and it extending to the elbow, and then the forearm would be the next section, involve the radius and the ulna, and the radius is the bigger bone on the lateral side, which is on the thumb side, while the ulna is on the medial side or to the little finger side. You finish the upper extremity with your wrist and your hand, and the wrist will be that joint and all the way down to the fingers. So the division of the wrist and hand, you have what you call the carpals. That's actually the wrist, and then you have the hands would involve the metacarpals, and the fingers, the phalanges. So there's a difference between the hand and the foot. When you go to the foot, it's gonna be tarsals for the ankle, and then you have for the foot would be your metatarsals, and phalanges will be just the same for your toes. So from the thorax, we go to the pelvis, which we say is part of the appendicular skeleton. So the pelvic girdle consists of the two coxae hip bones, and you have the sacrum, which is the fused section of the spinal column, which we say connects to the pelvis, and you have the coccyx, which is the tailbone. So each pelvic bone is formed by the fusion of three bones. You have the ilium, the ischium, and the pubis. So all these bones form the pelvic bone, and it's joined at the pubis to the front, where you have the pubic symphysis will be that joint. And looking at the diagram, we see here where the ilium, the ischium, and the pubis are all there, and you have the sacrum at the posterior area, which is fused, and you have the pubic symphysis in front, where you have the pubic bone meat, and it will offer some minimal movement. So posteriorly, the ilium, the ischium, and the pubis bones are joined by the sacrum, while anteriorly, the pubic symphysis is where the right and left pubis are joined. So recognize that structural connection at the pelvis. For the lower extremities, you will start from the hip bone, which is the femur, and that's the longest bone in the body. It connects into the acetabulum, which is the hip the socket, and it's a ball and socket joint. So the femur or the hip bone will go into the acetabulum, which is the ball and socket joint, and that's the formation right at the joining of the hip bone with the pelvis. That's the joint being formed there, and it's a ball and socket joint. The greater and lesser trochanter are where the major muscles of the thigh connect to the femur. So the greater trochanter is to the lateral aspect of the hip bone, which is the neck of the hip, and the inner one is the lesser trochanter. So it's just a prominence that you have on the neck of the hip bone or the femur, which allow for the connection of the muscles, and those are very powerful muscles of the thigh. So when there is a fracture, these powerful muscles will contract, and the bone end can be displaced and have the shortening of the limb. The lower extremity continues. You have the knee connects the upper leg to the lower leg, and you have the kneecap, which is the patella. So know these anatomical terms. As we said, it will help you when you are doing your handover and when you are doing your documentation. Persons will appreciate you more when you are using your terminology. They recognize that you know what you're about, and it's good for you to practice using them. For the lower leg, it's the bone, two bones you have in the lower legs will be the tibia, the shin bone, and as you go further, we're expecting you to be using these terminologies. So a lay person will say shin bone. Now you know that it's the tibia, and it's on the anterior of the leg. So that's the main bone you can feel in your lower leg, and the fibula would be the smaller bone to the lateral aspect of the leg. So know these bones, and that's the lower extremity. So you start with your femur, which is your hip bone, and then you move to your knee, which is the joint, and then you have the cap at the knee is the patella, moving through to your lower leg, which have the two bones, the tibia, known as the shin bone, and you have the fibula. The tibia is the larger of the two bones, and it's the more prominent to the anterior aspect of the leg, while the fibula is to the lateral side of the leg. As you continue to the end of your lower extremity, you have the anchor, and that's a hinge joint, so it allows only for flexion and extension, and that's because of the formation of the bones in that region and the ligaments and tendons that hold them in place. So it only offers for one directional plane of movement, which is flexion and extension. And then the last section of the lower extremity would be your foot. So as we said, with the hand, you have the foot, which would be the first section of it would be your tarsal bones, followed by the metatarsals, and then you have the phalanges for the toes. And recognize these key for the largest bone in the foot would be your calcaneus, and that's where you have your Achilles tendon connected. That's the, we say a tendon connect muscle to bone. And then you also have the talus is another large bone in the foot. So recognize that you have the 7 tarsal bones going towards the 5 metatarsal bones that form the substance of the foot, and then you have the toes, which will be your phalanges, just like the phalanges of your, which is your fingers. And that is your anatomy of the skeletal system. We said you have the axial skeleton, the appendicular skeleton, and we say that you have the skull, thoracic cage, spinal column for the axial, and then you have the arms, legs, and pelvis for the appendicular. Now, how the skeleton function, we talk about physiology. So the skeleton system, it gives the body its shape, its upright posture, it protects vital organs, it also allows for movements, and it stores calcium, and it helps create blood cells. So you must know these functions of the skeleton system. It's very important. And so when you come to pathophysiology, you need to recognize that if there's damage, if there's injury, disease, then these functions will be compromised. So give the body its shape, allow for the upright posture of the body, and it protects vital organs. We see where the skull gonna protect the brain in the cranium. You have the eyes in the eye socket. You have the heart. We see the heart, the lungs, the great vessels in the thoracic cage, and goes right through. We have the abdominal cavity, where you have the retroperitoneal organs in the pelvis, so that protection is there. And because of your tendons and your ligaments, you have movement. We will move to the musculoskeletal system, but recognize also that the bones store calcium, and we know that calcium is very important in strengthening of bones. And also in the bone marrows, you have blood cells are produced. As we look at musculoskeletal system, it's basically the skeletal system with muscles connected to it. So it's just added muscle to the skeletal system that we have looked at before. So it's gonna offer for form, upright posture, movement, and protection of the vital internal organs. It's just taking the skeleton to another level to show you how muscles are connected to it and how it gives those functions. So we have the different types of muscles. So there are three main types of muscles. You have the skeletal muscles, which voluntary muscle. These are the muscles that's connected to the skeleton, and they are known as striated muscle because of their stripe formation. And also you have another category of muscles. Those are the smooth muscles. We find these muscles in the blood vessels and the intestine. And there is one specialized muscle where you don't find it anywhere else but the heart. That's the cardiac muscle. So it's a muscle that is unique. It's in that it offers for automaticity. So it can operate without any external stimuli. All the other muscles have to have external stimuli to function. The cardiac muscle can generate its own signal and function without any outside stimuli or stimuli from the nervous system, which we'll look at further. So these are the muscles, the skeletal muscles, and so you will see the different areas. You know, you always hear talk about biceps and triceps. So those are the muscles that allow for the flexion and extension of the arm, and the biceps would be the muscles anteriorly, while the triceps would be posteriorly. And you also have another main muscle group, the quadriceps, those powerful muscles we say in the thigh. And you have intercostal muscles. You have pectoralis. So you can look at those different muscle groups. So when you look at the physiology of the musculoskeletal system, you have contraction and relaxation of system makes it possible to move and manipulate the environment. So you have muscles working and opposing each other. So for the biceps and triceps, one contract, the other one offers some counter force to, so you don't, when you raise your arm, you don't just suddenly hit your face because of the antagonistic muscles that are there to counter one. So they work in pairs. So you have contraction and relaxation of system makes it possible to move and manipulate the environment. A byproduct of this movement is heat. So muscle contraction generates heat. Another function of the muscle is to protect the structures under them. So your abdominal muscle will help to protect the organs in your abdomen. And you have other large muscle mass which offers protection all over your body. So that function is there for the muscles, but it's primarily the musculoskeletal. The muscles of the skeleton is for the movement. We are moving to the respiratory system, and this is basically an overview of the human body. You will be looking back at these systems as you go further into all of the medical and trauma emergencies. You'll be coming back to it, and as I said, you must grasp these fundamental concepts because it will take you through the rest of the course and through your career as a healthcare provider. You'll be coming back to these fundamentals, so ensure that you grasp them from now. The respiratory system is a very important system of the body. It's when we are looking at the anatomy of the respiratory system, we are looking at all of the structures that contribute to the breathing process. And we see where you have structures starting from your mouth, your nose. Behind your nose, you have your nasal passage. Behind your mouth, you have your oropharynx, and that's your throat. And from your pharynx, which is common for the oropharynx and the nasopharynx, you have that common pharynx, and that moves to your larynx. Above that larynx, you have the epiglottis, and then you move to your trachea, and it moves down into that division where you have the carina and divides into your bronchus or bronchi plural, and then you have the smaller bronchioles, and you're going into your lungs where you have the terminal bronchioles, and then you find the end point, which is your alveoli, which is the tiny air sacs. You have millions of these sacs in the lungs, which offers for the exchange of gases. And this is, in essence, the air passage, which allows for the air to move from the outside to the inside. Now we say all the structures of the breathing process involves other supportive structures. So you also have your diaphragm, you also have your rib cage, which play a part, and we will go, you have the lungs, and then you have your nervous system, which play a part in it also. But looking at the structures, recognize also that the air passage is divided into upper and lower. The larynx is normally the dividing point. So you can put the larynx as a part of the upper, you will not be wrong. You can put it as a part of the lower, you will not be wrong. It's the dividing point. So recognize the structures of the upper airway would be from your mouth to the larynx. The structures of the lower airway would be from your larynx to the alveoli. You have to know these areas and recognize what's happening there. So the structures of the body that contribute to respiration, those are the anatomy of the respiratory system. And recognize that the alveoli have tiny blood vessels wound around them, which would be the pulmonary capillaries. So we say that the upper airway, it includes your nose, mouth, which is the oral cavity, your tongue, your jaw, which is the mandible, and your larynx. And we say that the larynx divides upper and lower ear. So that's the dividing point. You can put the larynx in either one. The upper airway also includes the pharynx, and you lay term with the pharynx is your throat, and it's divided into the nasopharynx, which is the section behind your nose. You also have the oropharynx, which is the section behind your mouth, and then the laryngopharynx, or some term, when you go further, you refer to it as the hypopharynx. That is the lower section of your throat, where it's going towards that division point, and it's going into the larynx. So the pharynx is gonna subdivide into your trachea and anteriorly, while posteriorly you'll have the esophagus. So from the trachea you have the epiglottis, which is a structure, leaf-shaped structure, which is there to prevent food and liquid from going into the trachea. So it's the gate that is there. Once you're about to eat or drink, then it will cause the trachea to move up and close off with the epiglottis and prevent food and liquid. So only air should go into the trachea. So when someone choke, you have a problem where the food or the liquid end up in the trachea where it should not be. For the lower airway, it's you have the thyroid cartilage, which is your Adam's apple, and you have the cricoid cartilage, which is below the thyroid cartilage, and immediately between the two of them, you have the cricothyroid membrane. So you have the thyroid is a cartilage. Thyroid cartilage is a not solid bone, but it's and also the cricoid is a similar cartilage, but between the two you have a membrane. It's not cartilage, it's not bone, it's just a skin. Skin is there, and that's where you have surgical procedure can be done when you have upper airway blockage. Then you can create an incision there and allow for air to be given to the patient through that area. Below the thyroid cartilage and the cricoid cartilage, you also have the trachea continues, and the trachea ends at the carina, and that's about thoracic vertebrae T4 and or T5. That's where you have the branching of the trachea, and it divides into the right and left bronchi, and then it leads into the bronchioles. Understand these structures that are there. So part of the lower airway, you say you have the two lungs, and they are held in place by the trachea, arteries and veins, and pulmonary ligaments. So they are suspended basically, and they will allow for expansion because of the there's a lining that covers them. They talk about the pleura. So the parietal pleura connect to the chest cavity and the outer layer, while the inner layer is the visceral pleura, and it allows for the lungs to move. But they are suspended basically by the trachea and the veins and pulmonary ligaments. They are divided into two lobes. So the right lungs has 3 lobes, and that is so because it's of its full area, while the left lung, because of the position of the heart, it only has 2 lobes. So it only has upper and lower lobes, while the right lungs have its full capacity. It have 3 lobes, upper, middle, and lower. And we are looking at the anatomy of the respiratory system. Upper and lower airways, supporting structures. Within, as we continue with the lungs, within the lobes are bronchi, bronchioles, and alveoli. So once the trachea branches at the carina, it goes to the main bronchi, which enters the lungs, and it's further divided into bronchioles and alveoli, which is the last section. That's where the gases are exchanged. So we say that these alveoli are 1 cell thick. There are millions of them inside each lung, and they offers for that exchange of gases. So oxygen, which comes in the air that we breathe in, 21%, it's diffused through the walls of the alveoli and into the capillaries that wound around them and goes into your bloodstream. So we mentioned that you have the pleura, which is a layer of smooth, glistening tissue that covers each lung and lines the chest cavity. Between the 2 layers is a small amount of fluid that allows the tissues to glide smoothly. So it's almost like it's a no space is there, but you'd have that small amount of fluid that allow for that smooth gliding of the lungs. But in a sense, it's almost as if it's connected. So if the chest cavity moves, it will actually move the lungs and cause it to expand. So it's just a minimal layer of fluid there in essence. So looking at the lungs, this is what we should be seeing for the lower airway. It's you have the thyroid cartilage, which is your Adam's upper. That's right at your vocal cord, and you have the cricoid cartilage, and we said between the 2 areas is the cricothyroid membrane, and that's area is just skin. You have from the cricoid cartilage, you move to your trachea, and that's your layman term, your windpipe. And then that is gonna branch at your carina, which is at about the T4 or T5. The trachea branches into your main bronchi, and it subdivides into your bronchioles, and we say it's terminate into your alveoli, which is the ear sacs. And recognize that we said you have 3 lobes for the right lungs, and for the left lung we have 2 lobes. Now it's very important that you recognize, as I said earlier, that a structure that is there to support breathing. So you have the main ear passage, but you have supporting structures that helps in the breathing process. And I mentioned the diaphragm. So the diaphragm is that muscular dome-shaped structure that is, it divides the thoracic cavity from the abdominal cavity, and it's play a very important role in breathing. So it's the primary muscle of breathing. It also involves, you have the neck, which is a cervical muscle, which we call the sternocleidomastoid muscles. So it depends on, it gets its name from the points of attachment. So it's connected to your sternum and the mastoid process. And you have also the intercostal muscles, which are the muscles between your ribs. And also you have the abdominal muscles and the pectoralis muscles, which is some another outer muscles and the chest. So these muscles come into play when a person is having difficulty breathing. So once they're having labored breathing, then the neck muscles, the sternocleidomastoid muscles will come into play. They'll be using up the abdominal muscles and the pectoral muscles. But normally, the breathing process would involve the intercostal muscles and the diaphragm. So those are the main muscles for normal breathing. But once there is labored breathing, then the accessory muscles will come into play. So recognize those are the muscles involved in normal and abnormal cases. So you have to understand how the breathing process works. There are basically 3 parts to the breathing process. You can divide it mainly in 2, which you have ventilation and respiration. And we're using this term respiration, sometimes we use it loosely, but we are talking about the respiratory system, and that's the whole system that involved in breathing, supplying oxygen to the body. But you have ventilation is the process wherein air is brought into the body. So ventilation is the exchange of air between the environment and the body. You have to understand that term as we are laying the foundation for the human body. You must understand that the ventilation is the exchange of air between the atmosphere and the body. Then you have respiration, which is the exchange of gases, and it takes place at 2 levels, at the lungs level and at the tissue level. But we are looking at ventilation. So ventilation is further divided into 2 phases. So you have, in order for the air to come into the body, you must have the first phase, which is inhalation. Inhalation is the same as inspiration. So you must know these terminologies. Inhalation is the same as inspiration. So in order for inhalation to take place, which is part of ventilation, the diaphragm, which we said, which is a muscular structure dividing the thoracic cavity from the abdominal cavity, it lies right below the lungs. It contracts, and I told you that you have nervous system that play a part in the respiratory system. So the nervous system play a part, and we will come to nervous system, but some signal is sent to the diaphragm and the intercostal muscle, and the signal is coming to the diaphragm. It comes via the phrenic nerves. The phrenic nerves supplies the signal to the diaphragm, and the intercostal muscle nerves will supply signal to the intercostal muscles. And once that happens, then these muscles will contract. You will ask the question, what causes signal to come? When you need to go a little further, recognize that the breathing process is initiated or controlled by the level of carbon dioxide, but to a deeper level, it's the level of the acids in the body, so the pH level. So once CO2 is high in the body, then it will be acidic, and the brain will pick up the signal and will pick up the sensation and send signal to these muscles and cause them to contract. So you have to recognize that's how it's gonna be initiated. It's, in a sense, it's trying to blow off that CO2, get body to a less acidic state. And so that's the initiation of the breathing process, and the ventilation process will start with that inhalation process where these muscles contract, and once they contract, they cause the chest to expand. So once the diaphragm contract, it is normally in a dome shape upward position. Once it contract, it's gonna flatten, and also the intercostal muscles contract and cause the rib cage to go up and out. Up and out by the intercostal muscle rib cage, up and out, the diaphragm flattens. What you have in effect is that the thoracic cavity increase in size. Volume and pressure is opposite. So if I increase the volume of the thoracic, if the volume of the thoracic cavity increases, then what happens to the pressure? It is opposite. So the pressure will decrease, and therefore you have atmospheric pressure is normally higher than pressure inside of the thoracic cavity. And if I further decrease the pressure in the thoracic cavity, then that allows for the air to rush into the lungs. And that is how you have inhalation. You must understand this process and make sure you know to explain it from start to finish. Once the lungs fills with air, and that's the active part of the respiratory cycle. That's the ventilation cycle that's inhalation process of ventilation. So the opposite will happen. Once the air comes in and the body blow off that CO2, then the brain will pick up that there is not much CO2 and you don't have to continue that process, and the signal will be stopped to these muscles. So it will go back to the resting state where it's relaxed. The dome-shaped position of the diaphragm comes into play. The intercostal muscle relaxes, and the rib cage go back down and inward. What happened to the volume? The volume decreases. What happened to the pressure? The pressure increases, and air is forced out of the lungs. That is your exhalation phase. That is also your expiration. So recognize that is what is happening in the two phases, and you have to be able to explain it and understand it. Also, there are some pressure receptors in the lungs. Once it expands during the inhalation phase and it reaches a predetermined state, then these receptors will send signal to the brain and cause the signal to stop to these muscles. And that's how you will get the inhalation and exhalation. That's how you'll get inspiration and expiration. And you have to understand that cycle. I explained all of this already. So in exhalation, which is the same as expiration, the diaphragm and intercostal muscles relaxes. So the signal are not sent to them anymore, and they relaxes. And we say two things cause the signal to stop. The pressure receptors realize that the lungs is filling off, and also normally the CO2 will start to go down, and pH will start to goes to a more alkaline state, and so signal will stop, and that's what caused the diaphragm and the intercostal muscles to relax. the volume get back to decreased state, pressure will increase, and you have air being forced out of the lungs. Recognize that this is a passive portion or phase of the respiratory cycle because it does not need any energy as the inhalation phase where you have to have contraction of the muscles. So there's no energy involved in the normal process. Once there's problem with breathing, then you might find that the person now will have to be using those accessory muscles to actually help with even exhalation process. But that is when we come to pathophysiology. But during a normal physiological function, no muscle use is needed to get the air out in the exhalation phase. It's a passive phase, but usually because it's passive, it will take a longer time. So the passive phase, the exhalation phase, is normally longer than the inspiration or inhalation because it's the inhalation is active phase, so it occurs at a faster rate. So we look at the anatomy. Now let's look at the physiology. So the respiratory system main function or the function is to provide the body with oxygen and eliminate carbon dioxide. So it is to supply the body with oxygen and eliminate carbon dioxide. And we mentioned earlier that we have the ventilation and the respiration, and they are two separate, but they are interdependent functions of the respiratory system. So even though they are separate, they work together. If you are not having ventilation, then the end result will not be achieved, even if you are having respiration. And the opposite happens. If you have respiration and there is no ventilation, then you will not be able to achieve the function of the body getting oxygen and eliminate waste. So the two functions, the two processes must be going on. And there's a third process which we need to mention. You have to have oxygenation taking place. So even if you have ventilation and respiration going on, if you don't have oxygenation, then the end result will not be achieved either. So oxygenation is you have ventilation where the air comes in by the inhalation process. It comes into the alveoli, and we say that the air has 21% oxygen. It's gonna be there in the alveoli, and it have to be exchanged or moved into the blood vessel, the pulmonary capillaries that is wound around the alveoli, and that's through a process of diffusion where it high concentration in the alveoli of the oxygen, which is 21%. The blood capillaries wound around the alveoli have oxygen concentration of about 16% due to the fact that 21% came in prior. The cells use 5% roughly, and so 16% is returned to the alveoli to be exhaled. That process of diffusion takes place because of the difference in concentration of molecules of 21% in the alveoli, 16% in the blood vessel. And so oxygen moves from the alveoli to the blood vessel, the capillaries. At the same time, you have CO2, which is 1% approximately in inspired air, and you have the CO2 in the blood return to the lungs is about 3 to 5% because the cells would have given off waste, mainly CO2. So you have a higher concentration of CO2 in the blood capillaries around the alveoli. So the diffusion takes place in the opposite direction where CO2 is moved from the blood capillaries into the alveoli. That is the respiration number one. Now, oxygenation is when the oxygen reaches in the blood capillaries. It have to move to the tissue cells, and it cannot move in the plasma of the blood, and so it's bound to hemoglobin in the red blood cells. We will look at it further, but just recognize that you have to have oxygenation taking place along with your ventilation and your respiration. And that's the physiology you need to understand for breathing to take place, and the function of the oxygen reaching the body cells and the elimination of waste takes place. So we say respiration is the exchange of oxygen and carbon dioxide in the alveoli and tissues, and it provides oxygen to the cells and removes waste carbon dioxide predominantly. And diffusion, as I explained, is a passive process in which molecules move from an area of higher concentration to an area of lower concentration. You have to understand that this is a passive process again. It doesn't take any energy for this to happen. You have other process that takes energy away, like osmosis, but this diffusion process is a simple process of higher concentration molecule moving to an area of lower concentration, and it occurs because you have a medium, the membrane of the walls of the alveoli are very thin, as also the walls of the pulmonary capillaries that are around it. So it's easy for that diffusion to take place, and you have to recognize that's happening. Now there are some chemical control of breathing, and I mentioned it before. In order for the intercostal muscles and the diaphragm to get their signal, then there's some control that must be happening, and this control comes about from the high CO2 that is in the blood, and the spinal fluid. So this is picked up by sensors that are there, and it's picked up by the brainstem, and we will look further when we go to the nervous system. But the brainstem have sensors there that picks up the CO2 level, and it sends signal to these muscles to initiate the process of the breathing. And also you have the primary reasons for breathing is to lower the carbon dioxide level. So you want to blow it off so that the pH level will not be so acidic. So that's the primary reason. And also recognize that, so the primary drive to breathe is based on the CO2 levels, but there's also a backup drive, which we call the hypoxic drive. And this backup drive, the hypoxic drive, as the name suggests, deals with oxygen levels. So once the oxygen level is low, this drive will be triggered. So the two of them work together, but the less sensitive because most of the time it's easy to get your O2 level up. So normally your primary drive gonna be the CO2 levels, and that's where the CO2 gets high. The brainstem picks it up and send the signal to the intercostal muscle, the diaphragm, and stimulate them, and you generate the inhalation process, and that system continues. The nervous system also plays a part, as we said. So the medulla oblongata is an area of the brainstem, and that's the brainstem is a part of the nervous system as we look at further. But that area there, you have the medulla oblongata and you have the pons, and also so these two areas will determine the rate is set by the medulla oblongata, and also you have the pons will determine also the strength and depth, or the regularity and the depth of the breathing. So recognize that the nervous system play a part in the breathing process, as I said before, and also it's dealing with the chemicals, CO2 levels, which goes deeper to the pH level, and also the O2 levels. But is the nervous system have that control over it. So the diaphragm is, we will look also, is a voluntary muscle, but predominantly it's going to be a involuntary muscle, because you will always be breathing, and also you will try to stop your breath So you can voluntarily control it for a while, but you cannot stop your breath forever. So it's predominantly a involuntary muscle. So that breathing process will continue without our control, and that's been regulated by the brainstem. As we look at the physiology, we said that ventilation is simple air movement in and out of the lungs, and it requires chest rise and fall. So when you're assessing your patient, once you reach to breathing check, you first want to know, is the person breathing? Yes or no? Are you seeing rise and fall of the chest? Yes, then you need to assess it. So it should be adequate rise and fall, which means they are getting good tidal volume. So ventilation, we said, involve inhalation and exhalation. So that's the rise and fall of the chest. Tidal volume is the amount of air that it moves in and out of the lungs during a single breath. So in inhalation, rise. Out exhalation, it's fall. That amount of air that is moved within that one breath is called your tidal volume. The residual volume is the gas that remains in the lungs to keep the lungs open. So when you exhale, all the air does not comes out, otherwise the lungs would collapse. So there's a residual volume that is there to keep it open. No matter how you try to exhale all you want, then that some amount of air will remain to keep those lungs open. Sometimes you get winded and it feel like all the air comes out, but normally there's a residual volume, and you need to recognize you have to have adequate tidal volume to get the amount of air that you need to pass through, because there's something that they call a dead space, and the air has to pass through that dead space before it actually reaches to the air of the alveoli, where you have that exchange taking place. So if you are not getting enough tidal volume, then you won't have enough air to reach to those alveoli to give adequate exchange. As we mentioned, a dead space there. So it's the portion of the respiratory system that has no alveoli and where little or no exchange of gas between air and blood occurs. Now the respiratory rate and tidal volume times tidal volume will give the minute volume. So there's a tidal volume, which is per breath. Each breath you take, you have a volume of air comes in. And roughly for the adult, you're looking at 450 mils of air. For the so for the minute volume, you multiply the person's respiratory rate by each breath at the tidal volume, and that would give the minute volume. So what are the characteristics of normal breathing? So we talk about the anatomy and the physiology, the structures that make up the respiratory system, and we look at how they should be working to get your ventilation and your respiration and your oxygenation going. Now, if that is happening normally, then these are the characteristics you should be seeing or hearing or noticing. So the first thing is, for normal breathing to be occurring, you must have a normal rate and depth, and that's what is your tidal volume. So each breath you take, you must have adequate rise of your chest to bring in that amount of air that is needed or required. And for the adult, we know that it's 12 to 20 breaths per minute. That's the normal rate you should be getting. And for the depth, you should see pronounced rise and fall of the chest. So it should be pronounced rise, you should be observing. If it's barely rising, then that's shallow. That's not adequate. It must have a regular pattern of inhalation and exhalation. As we said, this pattern is continuous, the brainstem regulating it, and it's gonna be a constant pattern. Once there is a change in the pattern, so if you are counting it and you see, you get between your count 1, 2, 3, and there's a rise. You're expecting to see the next rise after the same 1, 2, 3. If you are seeing 1, 2, 3 and a rise, and then you count by the time you reach to 2, there's another rise, or by 1, there's another rise, then that's irregular pattern of inhalation and exhalation. it should have a pattern established. It goes like clockwork once it's working normally. Once it's abnormal, then it's saying that some damage could be done to the brainstem, which you say is what regulates it. It should be clear. So normal breathing process, it is effortless, we said, noiseless. And so it should be clear, audible breath sounds on both sides of the chest. So if you auscultate, you should hear clear lung sound. You shouldn't be hearing noise even from without auscultating by the person's breathing. That's not normal. And you should have regular rise and fall movement on both sides of the chest. So it should be symmetrical. It should not be rise on one side, fall on the other side. Whatever is happening on one side, it's the same to be happening on the next side. So rise same time, fall same time. Movement of the abdomen. Remember, we say that the diaphragm is there, so you will observe movement in the abdomen. When we look at the developmental stage, lifespan, you will observe that for infant, they are mainly belly breathers because their chest cavity, thoracic cage is not fully developed. So they will breathe mainly, they're going to rely on the diaphragm mainly. But for normal process, you should see movement of the abdomen because the diaphragm is there right in that boundary. And once you know normal breathing, then you can know what is abnormal. So everything that is normal, opposite will be for abnormal. So the rate will not be within the 12 to 20. You will have irregular pattern of respiration. You will have shallow breathing. So all of the factors that makes it normal, it will be the opposite for abnormal. And so inadequate will be characterized by labored breathing. We said normal breathing should be effortless. You shouldn't be using those accessory muscles. You shouldn't be seeing the sternocleidomastoid muscles being used, the neck muscles. You shouldn't be seeing the pectoralis major muscle being used. You shouldn't be seeing the abdominal muscle being used excessively. So it should be effortless. Just the intercostal muscles and the diaphragm should be working on a normal condition. The muscle, you shouldn't be seeing muscle retraction where you see the skin being pulled around the chest. You shouldn't, the patient should have a pale, cyanotic, cool, damp skin because cyanotic is blue. That's because of deficiency in oxygen. Normally the oxygen, because of the hemoglobin, will give you that pink color. And pale would be indicating that there is some deficiency in the blood going to the ear. Tripod positioning, again, we say it should be effortless. So tripod position is where the person sit leaning forward. Adult will be on their outstretched arm because they're trying to balance up their weight and put themselves in the best position to get the air going into their alveoli, going to the lungs. And for children, they will be in the sniffing position where they are upper body is lighter, so they won't necessarily be on their outstretched arm, but they are leaning forward, sniffing. And you can have agonal gasp. These are dying breath. This is just the same diaphragm and intercostal muscles will be getting their signal, but it is not effective breathing. So that's once you're observing that, you can almost say that that person is not effective breathing. So if you are determining breathing for a person, whether to do CPR or not, if it's agonal breathing, then gasp, then it is not considered as not effective breathing. So you no pulse with that, you would start CPR. So you must know what is normal, and from how you know normal, you just need to know the structures and how they function, and you can know exactly what you should be seeing when you go on a scene to assess your patient. This is what the level you want it to reach, where you can know exactly what should be happening, and then once you see something else, then you can know what is the cause of it. And that's why we say anatomy, physiology, and knowledge of anatomy, physiology, pathophysiology will help you well as you go in your career as an EMT. So we are going to circulatory system anatomy, complex arrangement of connected tubes, and this is a closed loop system. It's made up of we call it the perfusion triangle or the cardiovascular system. So it's your heart, your arteries, the heart, the blood vessels, and the blood. That's gonna be your circulatory system or cardiovascular system, perfusion triangle. But as you look at the anatomy, you're looking at the arteries, arterioles, capillaries, venules, and veins. So these are blood vessels. So blood vessels will be carrying blood from the heart to your tissues and to the lungs. So you have two circuits involved. You have the systemic circulation, which supplies blood to the body, and you have the pulmonary circulation, which supplies blood to the lungs. And we will see here a diagram, and you must get these fundamentals. I will try to go through it so you can understand it as best as possible. So we say that the circulatory system or the cardiovascular system or the perfusion triangle is comprised of the heart and the blood vessels and the blood. And this is what you need to understand. The heart is the pump that will pump the blood through the two systems that we mentioned. Two types of circulation, the systemic circulation and the pulmonary circulation. So if you want to start at any point, recognize that the heart is a muscular organ, which basically is two pumps working as one. And there are two sides to it. So you have the right side and the left side, and recognize that we're talking the directional point of the patient. So when I say right side, picture they are looking at the patient and it's the right side. And also there's a middle area of the heart, which is the septum, that actually divides into two separate pumps. So nothing from the right side pump will be going over into the left side pump as long as you're born. That's the situation. When you're a fetus, you have a hole in the septum, but once you're born, that hole is sealed up and you have no communication between the two pumps anymore. So on the right side of the heart, that's where you have bad blood, what you call deoxygenated blood coming from the body tissues, and it has been deprived of oxygen, so we call it deoxygenated, but it's not fully without oxygen, but it's, as I said before, you have about 16% oxygen in it, but it's returning to the heart after it has been used by the body tissues. So that will come to the main vein, which is your vena cava. So the lower portion of the vena cava is the inferior vena cava. It's gonna take blood from the lower part of your body, from your lower extremity, your hip, your pelvic, coming all the way up, abdomen. It's gonna carry that blood from there, returning to the heart, and it's gonna join with the next portion of the vena cava, which is the superior vena cava, coming from your head, your shoulder, your upper body, and it's gonna join and come into your right atrium. So the heart have two sections, two sides, and it's further divided into upper and lower chambers. So the upper chambers are the atrium, the lower chambers are the ventricles. So the blood, deoxygenated blood, oxygen poor blood, will return via the common vena cava into the right atrium, and it will go in through valves which are in the heart. So the valve that is in the right side of the heart separates the atrium and the ventricle, is known as the tricuspid valve, and it is allowing blood to go into the ventricle when it opens, and while it is filling, while the ventricle are contract, then it will close to prevent the backflow of blood. Once that blood goes into the ventricle, when the ventricle contracts, it will move out via the pulmonary artery. Recognize that arteries will always take blood away from the heart. Artery, the A in artery, away from the heart. So it will take the blood away from the heart, and it's a pulmonary artery, so it's going to the lungs. So it branches into left and right and supply the left and right lungs. That's your pulmonary artery. But it also goes through a valve. So there are valves that control the flow of blood in one direction. So the tricuspid valve allows the blood to flow in one direction from the right atrium to the right ventricle. It's gonna go via the pulmonic valve, and that's gonna allow it to go into the pulmonary arteries. Once it goes to the lungs, it's gonna get oxygenated, so it will give up the carbon dioxide that was in it from the metabolization of the cells, and so the exchange, as we talk about in respiration, will take place, and you have CO2 coming from the body tissue, coming from the right side of the heart. It will comes in via the pulmonary capillaries and give off that CO2, which we say is higher concentration than the air that is in the lungs, alveoli, and it will pick up O2, which is a higher concentration now, because 16% is gonna go to the lungs, and then you have 21% in the alveoli. So it picks up more oxygen, and it's gonna return via the pulmonary vein. So all veins will come to the heart. So once you know one, you'll know the other. And the easy way to remember, arteries A away from the heart. Vein will be coming back to the heart. Now, normal rule is that arteries carries oxygenated blood, while vein carries deoxygenated blood. But there are one exception to this rule. You have the only artery that carries deoxygenated blood is the pulmonary artery. And the same goes for the pulmonary vein. It's the only vein that will carry oxygenated blood. So understand that what is happening. The pulmonary vein will carry that blood which has been oxygenated now to the heart, and it's coming to the upper chamber. So upper chambers of the heart will always receive blood, while the lower chamber distribute blood. So the left side of the heart is the most muscular side, is the most powerful side, especially the left ventricle. It has the bulk of the work to pump blood throughout the whole body, except for the circulation to the lungs. So it's gonna come via the left atrium, which is a upper chamber collecting chamber. It's gonna pass through another valve, which we say control the flow, and this valve is now opposite to the tricuspid valve. It's gonna be the bicuspid valve. So easy way for you to remember these two valves, which separate the atrium from the ventricle, is to remember that T in tri, and not T, the R in tri is the right side. So once you know one, you know the other. If tri on the right, then bi is on the left. Another name for the bicuspid valve is the mitral valve. Once it passes through that valve, it's gonna come into the left ventricle. When the left ventricle contracts, it's gonna push it out. The blood is gonna go out to the main artery, which is your aorta. But again, we say there's a valve which it must pass through, and that is your aortic valve. And then it goes to your aorta, where it's gonna go to your aortic arch. It goes to your ascending aorta and the descending aorta. So the ascending aorta send the blood to the upper body, the shoulder, your head, and it's gonna come to the descending aorta, which goes to your lower body, and the cycle continues. And you must be able to explain this circulation. You must know the different sections of the heart. You must know the different flow of blood. And also we talk about the systemic circulation. So the systemic circulation will start from where the blood leaves the left ventricle via the aorta, and it goes to the body's tissues, and it's gonna come and return to the right atrium. That is your systemic circulation. The pulmonary circulation is from the right ventricle, where it leaves via the pulmonary artery and goes to the lungs, return to the left atrium. That is your pulmonary circulation. So the pulmonary circulation is not under high pressure as the systemic circulation. So the systemic circulation is a high pressure circulation because the heart have to pump the blood to the whole body. All the body tissues will have to get the blood except the lungs via that systemic circulation. So it's a high pressure system. The pulmonary circulation is more low pressure system. You need to recognize all of this and be able to explain it. This is fundamental concepts you have to grasp from now and be able to explain all of it. So I've explained all of this. I'm just going to run through it quickly. So the heart, we said, is a hollow muscular organ made of specialized cardiac muscle, works as two-paired pumps. Each side is divided into atrium, upper chamber, and pleural will be atria, and ventricle, lower chamber. So we say the upper chamber, the atria, will always collect blood, while the ventricles distribute blood. That's where the blood pumps from. The heart, we said, it's circulation. The heart receives this blood from the aorta. So the heart is an organ, so it has to be supplied with blood also. So even though the heart is responsible for pumping blood through the body, itself needs its own blood supply. So it's gonna have its supply from the aorta. So once the blood comes out in the aorta, the aortic valve is going to close when it's relaxing. So under contraction, the aortic valves open and the blood is pumped out. Once you have relaxation, then there's a backflow of blood which is going to come right at the base of the aorta. You have the blood vessels that supplies the heart itself, which are called the coronary arteries, and they also have coronary veins. So the blood is going to go via the coronary artery to the heart muscle, and it's going to return via the coronary vein back to the left side, the right side of the heart. So the heart receives its blood from the aorta, but it's not under pressure when it pumps out in systole state, because it's going to be too much pressure to go to those tiny coronary artery. The right side receives deoxygenated blood from the vein. The left side receives oxygenated blood from the lungs. And I explained all of that to you. You have to understand that what is happening. And we said it's deoxygenated blood, but it's not to say that it's totally free of oxygen. There is some amount of oxygen still, but it's less than what came in. Now we are looking at another diagram which gives you another dimension to it, and I explained all of this to you before. So you will see the division there, the right side, and we're talking about the patient's right. So you will see the right atrium there with the vena cava coming in, the superior from the head, the inferior from the lower section, and it comes into the right atrium, passes through that tricuspid valve into the right ventricle, and then it's gonna go via the pulmonary artery through the pulmonic valve and goes to the lungs, gonna return via the pulmonary vein into the left atrium via the bicuspid valve and into the left ventricle. Under contraction, it's gonna be pumped out via the aorta, and you have the aortic arch there, and then you have the ascending and then descending aorta. And that's basically the image that is showing there. So you have to know the direction of the flow and can explain all of that. So the right lower pressure side of the heart pumps blood from the body through the lungs, and that's your pulmonary circulation. The left higher pressure side of the heart pumps oxygen-rich blood to the rest of the body. That is systemic circulation. Now you need to recognize that the resting heart rate is 60 to 100 beats for the adult. So the adult resting heart rate is 60 to 100 beat. We mentioned, so just like how you have tidal volume for respiration, you have stroke volume for circulation, and that's the amount of blood that is moved by one beat. So one cycle, one contraction will give the stroke volume, and average stroke volume should be about 60 to 70 mils of blood in one stroke. Now, just like how you have minute volume for respiration, you have cardiac output is also the amount of blood that is moved in 1 minute. So that is your cardiac output, and that is the heart rate times the stroke volume. You need to know these terminology and these formulas. So the stroke volume is amount of blood moved by one beat, and you must know the rate. For the adult is 60 to 100 beat. You have conditioned athlete who will have under 60, and that's normal for them. When you're exercising, then the heart rate will go up, but normal resting rate is 60 to 100. The cardiac output, the amount of blood that moves in 1 minute, will be that heart rate times the stroke volume. And we say roughly 60 to 70 mils in a stroke. For the cardiac output in 1 minute, it would be, if the person's heart rate is 60, then 60 times is 60 or 70. And that's how we say that the average person have about 5 to 6 liters of blood in their body for the adult. Now the heart, we said, has cardiac muscles, and we said that that's the only type of muscle in the body. It's a specialized muscle, and it has what we call automaticity. So it can generate its own signal independent of the nervous system. It doesn't have to get a signal from the nervous system. The nervous system play a part in it. It can help to regulate it. It helps to regulate it, but without the regulation of the nervous system, the heart is gonna generate its own signal. So all muscles, and we say the heart is a muscular organ, all muscles normally would need a stimulus to cause it to contract. And so the stimulus normally comes via the nervous system, which deals with electrical impulses, nerves impulses. And so the heart has that electrical conduction system. And this is a specialized type of pathway that you have within the structure of the heart, which allow for this conducting of electrical current. So the electrical conduction system is a specialized tissue capable of initiating and conducting electrical current. And so it causes smooth, coordinated contractions. And the contractions produce pumping action. So therefore, recognize that you can have the electrical system working properly, and you can have a problem where you don't have the contraction. So when we look at the ECG, that will show the electrical system going on, but it doesn't tell you that you will necessarily have to have contraction. But that is what the system is about. The electrical system should provide that signal, and it should give rise to coordinated contraction, and then that should give rise to the pumping action. Now, this system starts at what you call the SA node. So in the heart, you will have the signal generating at what you call pacemaker sites or nodes. So the initial site in the heart that the signal start is the SA node, and that's at the upper section of the right atrium. And the signal generate there will give the normal rate, which is say 60 to 100. The signal will move from there to some pathways going to the second node, which is the AV node, and that AV node is right at the lower section of the right atrium, and it will move from the AV node, which is the atrioventricular node. The SA node is the sinoatrial node, and it will move from the AV node to the bundle of His, and where it's gonna divide into the septal wall and goes to the walls of the ventricles, and it's gonna move into what we call Purkinje fibers, and that's what's gonna cause the atrium to contract when the signal pass through and the muscles are working properly. Then the signal passing from the SA node generated at the 60 to 100 beat will pass through those nodal pathway and go to the AV node, and that should cause the atrium to contract, and it's gonna spread out across also to the left atrium. So whatever is happening to the right is the same thing simultaneously happening to the left, and the signal come down through the AV node, the bundle office, the left and right bundle branches into the ventricles and Purkinje fibers and cause the ventricles to contract. That's how the contraction works. Also recognize that this AV node will offer less rate than the SA node, and that's happened when the SA node fail, the AV node will pick it up, and that's 40 to 60 beat. And if the AV node fail, then the signal can be generated in the ventricles at 20 to 40 beats per minute. We mentioned also about the different blood vessels. So we said the arteries carry blood from the heart to all body parts, all body tissues, and the aorta branches into the coronary arteries, the carotid artery, the hepatic artery, renal artery, the mesenteric artery. So all of these are the subdivision of the main artery, which is the aorta, and it supplies the body with blood. So we say the coronary artery is the one that feeds the heart itself with its blood supply, and you have the carotid arteries, the arteries going up to your head, and the hepatic supplies the liver, renal the kidney, and the mesenteric supplies the intestine. So all of these are divisions of the arteries. You will also recognize that arteries will further subdivide into arterioles. So as they leave the heart, the big main vessel is the aorta. As it goes further away from the heart, it's gonna get small, because the aim is that it should reach the tissue. And we said that the smallest building block of the body is the cell. So you could not have that big aorta going straight to a cell. So it's gonna divide down into smaller sizes as it goes along from artery to arteriole, and then as it reaches to the cell in the tissue, it should be reaching down to capillaries. That's where the exchange is gonna take place. So pulmonary artery carries oxygen poor blood to the lungs, and we said this is the only artery that will carry oxygen poor blood, because normally arteries will carry oxygen rich blood. So the arteries branch into smaller arteries, and then arterial arteries branch into a series of increasing smaller vessels until they connect to capillaries. So from the arteries will give rise to pulse. So once the heart contracts and the blood exit into the aorta, which is the main artery, then it will create wave-like motion, pulsation along the vessel, and you will observe or palpate it at region where the vessel passes near to the surface and over a joint or a bone or a large muscle mass. So you will palpate it, and it's most easily felt at the neck, where you have the carotid artery. You'll have it at the wrist, which is the radial artery and pulse, and you will have it at the groin, where you have the femoral artery give rise to the femoral pulse. Now you will have, it's created by forceful pumping of the blood out of the left ventricle and into the major artery. So that's how you have the pulse, and we'll move further into where you have pulse will give rise, this pressure will give rise to blood pressure. But we'll be coming up on a break shortly. We are gonna break as we finish this portion here. It's a lot of material to cover, and it's the fundamentals, and you have to ensure that you grasp it. So these are the arteries that perfuse the body and give rise to the pulse point. So you will see the vast network. You will have the aorta, as we said, branches and give rise to the carotid artery going to the head. You will have the radial and the ulnar artery coming on the arm, the radialis and the lateral aspect in line with the thumb. You have the descending aorta, give rise to the common iliac artery. Then you have the femoral artery as it passes through the groin and going down to the knee. You have the popliteal, and going down to the ankle you have the dorsalis pedis and the posterior tibial artery. All those are points that you will know to find the pulse. So you have the carotid artery give rise to the pulse at the neck, and the radial artery give rise to the pulse at the wrist, the radial pulse, and you have the femoral pulse, you have the dorsalis pedis pulse, you have the posterior tibial, and that's the inner part of the anchor for the posterior tibial. You can pay attention to those. And we will just finish off with capillaries. So recognize that capillaries is the connection between the arteries and the veins, but we say the artery is gonna branch into the smaller point, which is the arteriole. As it gets smaller, going towards the tissue and the cells, and then you have the venule, which will be the return. Because the cardiovascular system, the circulatory system, is a closed loop system. So it comes from one side of the heart, the left side, comes to the body tissue, and it's gonna exchange at the capillaries, which are basically one cell thick, and that exchange takes place, and the blood continues going back to the right side of the heart via the venules, which is the smaller one, connecting to the capillaries, and then it gets bigger as it goes back to the right side, where you get back to the vein, which will the biggest vein will be the vena cava. And we will take a break here for 15 minutes, and we will come back at 10:45.